made this really nice transition from things on the outside and the ultimate in wearables and exoskeletons and techniques like that to things that are transient on the outside and slightly moving inside. But now we're going to go way inside, and that's with no one better that can take us on that journey than Miguel Montero Baker. Miguel has had a long provenance and history and training from Leipzig to Arizona. He's now out in the real world in practice, but he's an old soul, S-O-L-E. And but on the vascular side, and I think he's got a great future ahead of him, but I think his future has already arrived, particularly in work with implantable sensors, and I think this is going to have a real promising, potentially game-changing trajectory. Help me welcome Miguel Montero Baker.
Thank you, everybody. Dave, I'm not sure if is there like an underlying meaning to that? I sense something deeper in my body. I don't know if you're trying to get to anything, but I feel love for you. That's what's deep in me, and so that's all I can say. I don't think I'll dash through slides. I think I could probably get through this in less than 20 minutes, so I'll get us back on time. But if there was anybody here while we were discussing the term orphan heel that we've been trying to put out here, this is one of those patients that actually was kept in a podiatric care and family practice for a while because all of his forefoot labs and vascular evaluations were absolutely normal, and on top of that he had a normal dorsalis pedis pulse. As you can see the angiogram on the side, there was no perfusion to the heel. And so we went in depth yesterday to define this. But today what I want to tell you is that we do have, unfortunately, suboptimal ways to measure perfusion in a global way in our feet. And this is another of those slides that we had. In this particular subset of patients, we see that there's a prominent disease pattern that affects mainly the vessels that go to the heel. But when you do a toe brachial index, it really just measures the front of the foot and not the back of the foot. And like that, there's many other examples. Well, what if you cut and clip those 5 toes? Well, how can you do a toe brachial index? Or what if you have a flagrant infection? And now you find a lot of things. Crap, I mean, patients are sent back to me because they had a dressing. We can't do labs because there's a dressing. Well, take the dressing down and do the lab. But there's many things that certainly make us understand that it's not clear how to gauge how ischemic these patients are sometimes. And on top of that, as operators, now that we know that we could put a wire pretty much in any part of the body, we really have suboptimal performance goals. So, I mean, the best I could show you is from a consensus that comes from inner societies, and it says there's increasing evidence to support a recommendation for angioplasty in patients with CLI and infrapopliteal artery occlusion where inline flow to the foot can be reestablished. Well, what the heck does that even mean? Inline flow, there's 3 vessels. I could probably get inline flow to any one of those vessels. Am I actually achieving something? Should I do 1 or 3 vessels? What am I trying to get? And I think you've heard a lot from our group back in Tucson of the U of A in regards to trying to create perfusion markers by utilizing indocyanine green angiography. And I think that's a great tool, and we've been using that more and more. But that thing that's on the side, it's the size of that thing that's actually taller than me, and we have these minions running around with this thing all over the hospital and then taking it into the OR and cleaning it, and then you have to kind of prop the leg outside of the OR table and try to set everything up. So there's an issue with portability and the use you can give to it during a surgery. It's really not practical. So this is a heel ulcer in a patient that had been stagnant for a while, failed all sorts of medical optimization. And when you see the angiogram, you could see that's actually an occluded posterior tibial. There's actually a kind of a little lesion there 50 or probably 50 to 70 at the tibioperoneal trunk, which is going to be the one in the middle up high, and then maybe a wisp of something at the anterior tibial, and a lot of collaterals. So when I'm in the operating room, well, what the heck do I put my attention to? Where should I put my efforts in? And I can tell you, one of our biggest criticisms to the quote-unquote lesionologists, which exist within us as surgeons and also in other specialties, is they would probably go crazy and treat probably 5 or 6 of these. And then you could probably do a list of up to 20 CPT codes. That said, we have a long, complex PT occlusion. We have inadequate plantar target for landing zone. We have mild to moderate anterior tibial disease, moderate to severe peroneal disease, and then a bunch of collaterals. So what's enough? And not that I want to bore you with the technical details, because I know that not everybody here is a surgeon, but this is what we face when we see these patients that you will send us. You could treat many things. The question is, what's the right thing? And I think this goes to explain a lot of the mishaps that have happened in endovascular therapy. You heard a group of very well recognized physicians yesterday saying pretty much that endovascular therapy is kind of not the best thing in the world, and surgery should be the response or the best solution in maybe most of the cases, and then you could do endo. My impression is that we've had no performance goals whatsoever, and that's why endovascular therapy has shown to be probably substandard, because when you don't train people the same way, when all of the tools do different things, and when you go in there and you have no idea what you're treating, then it's really hard to come out with a good outcome that could be comparable with surgery. So the micro-oxygen sensing platform is something I stumbled upon actually via Dave. He had an initial conversation. It was a group of geeks from San Francisco, and they had this idea in their head, had no idea, had really no objective or what they could do with it. And then they said, well, why don't you talk to Miguel and see what you guys can come up with. So this is an injectable oxygen-sensitive hydrogel that's placed in the subcutaneous tissue, and then there's a signal detection that comes with it. And these are particles that there's chemical bonding particles that go into this that will pretty much be excited by a light that is generated by this sensor. And then when the particles get excited, then they can actually measure the amount of oxygen within the milieu where you put them. And that's not that you're going to walk around like a raver with all these lights all over. This is actually a special camera that allows you to see this chip, and that's inside somebody's body, but you can really, under normal circumstances, not even be aware that you have it. There's many other ways in which we now sense oxygen, but one of the things also, and I'm stealing a lot of ideas from what I've seen in the last couple of days because the talks have been amazing. Dr. San from the U of A also yesterday was explaining some of the bigger limitations we have with these things. So temperature is an issue, and well, depending on the skin type, it's an issue. And with this particular devices, you're really putting it right into the tissue where you want to sense the amount of oxygen. So it really doesn't have to do with the saturation of oxygen. It really doesn't have to do with the pressure or the perfusion. And it doesn't have to, there doesn't have to be an impact created on the skin like the TICO, where you have to actually create some degree of hyperthermia and then expect some of that oxygen to ooze out and then sense it. So the Si Se Puede trial, which is in clearly Spanish and it just means it can be done, it was a really small study, which I'm very proud to say was done at my old lab in Costa Rica. I still act as a co-director of a lab in Costa Rica where we do limb salvage, and now we're starting to do a lot of research. And so what we did here is a prospective observational single-arm study on 10 threatened ischemia, kind of ischemic legs in patients that were going into a planned revascularization via endovascular means. Operators were blinded, so we had no idea what was going on with the sensors, but we got to see the results later. So we just went in and we treated all these patients as we planned to, and then we looked at the results. We certainly went on and tried to put sensors in and around the ischemic areas, and they go through a 22 gauge needle, so it's really a small puncture site that you do. The probe, the sensor itself is about 1 to 2 millimeters. And in this very small initial study, what we wanted to do is it's a safety and efficacy. So bear in mind, I'm not trying to convince you that this helps in any way, shape, or form. Just some of the observations that I think will be a segue to maybe something more important in the future. All the demographics are pretty much in place with all of our patients. Most of them were around 70 to 80 years old, and they all had critical limb ischemia or threatening ischemic threat, limb-threatening ischemia. And we did have difference in the anatomy. So we had aortoiliac disease that was part of it. Then we had some femoral popliteal patients. And then we had some below-the-knee patients that were diabetics. And so bear in mind that that's important because some of the results. So as you can see, this is the first iteration of this device. So there's a lot of creativity in how to attach them and clearly a lot of tape. But that bulky device has now, as you saw in the first few slides, changed into a very nice smaller device. And this is a patient that had a long popliteal occlusion and then 2-vessel runoff to the foot. And so in this patient, we were able to cross that lesion, we prep that vessel, and then we put a superior stent. That's one of the stents that we use for this specific region. When we got to see the data, interestingly enough, and the lines in red are when we did balloon inflation, and the lines in green are when we did balloon deflation. And then the blue is the line when we actually put the stent in there. And you could see how when you inflate the balloon, the oxygen kind of comes down, and then you deflate the balloon and then probably restore flow, and then the oxygen content comes up. And then you, again, put the balloon up, then it kind of comes down and it dips. And then when you open it, finally at the end, it's a very increscendo oxygen sensing curve. And then usually the stent, for those who do this, is really not for acute perfusion. You use it kind of to acquire a longer result from your result. So the stent kind of at the end of the procedure, was just accompanied to the same increase. On this other patient, this was a patient that had a failed aortobifemoral bypass, and that was the only trickle feeding into his left leg. And as you can see, it's a fairly diseased aorta that goes into a common femoral and only a profunda, so he didn't even have an SFA. And with that patient, again, in the midst of a failed bypass, and a failed actually AX-FEM bypass on top of that, what we decided to do is optimize what we could. So we came from the arm, and we went through those arteries and pretty much angioplasty the whole iliac system and put stents all the way down to the profunda. What he had was rest pain, so he didn't have an ulcer specifically. So we thought that by increasing the flow into the profunda femoris, we would get this patient at least to feel much better. Well, interestingly enough, after the procedure and during the procedure, when we saw the curves afterwards, there wasn't really that much change initially. So that acute change that we saw when we were working below the knee and in the pop area was not the same when we were working via collaterals. And actually, that's something that we see in surgery. Sometimes when we do common femoral endarterectomies and we just allow the profunda to be the only vessel, those patients kind of come out of the OR with a fairly cold leg. And as the profunda recruits the genicular collaterals, then it kind of starts pinking up, and usually in the next morning they look very good. And this is what happened. We actually left those sensing platforms in, and we send them to the recovery room, and you see how probably about 20 or 30 minutes once he was out of the room, he started picking up really good. And actually, from the clinical standpoint, he did really well. So looking at a way in which we can try to be objective about this is we came up with this term called dynamic relative oxygen index, or DROIDs. And I think that's the only robotic part of my talk to be in this panel, actually. But what we did is we actually put one of those sensors in the arm, and then we put 3 in the foot before the procedure. And so then what we did is we kind of did, think about it, kind of an ABI, right? We were seeing what the oxygen content in a well-perfused limb was and comparing it to the oxygen content in a non-well-perfused limb. And you see the medians that show that pre-op, everybody was kind of on the lowish side, and post-op, then they come up, and then for the next 4 weeks, they remain higher. Now, granted, there is a lot of noise, and some of the sensors, still need a lot of mathematical algorithms to be corrected, but you start seeing a trend where you can actually sense these, and they're fairly stable in the next 4 weeks. And this is just oxygen concentration. And this comes from, again, the arm pre and post that shows pretty much no difference, and then the foot pre and post. And this is in micromoles, also another one of the factors that we had. So I think the MOXIe sensors, what we were aiming to in this specific very small study was, are they safe? And are patients having any reactions in their skin? And because the polyhema, that's the platform where you actually put the chemicals that bond to it, has been already safe and it's FDA approved. It's used in other implants like eye implants. So patients didn't show any reaction. It's not bioabsorbable, but it is biocompatible. So it'll stay there for a long period of time. And again, that's the polyhema vector. Now the sensing platform that gets into it will have a decay and eventually will stop sensing. But the great thing about that is that we've now realized that we can have oxygen concentration up to 372 days. And that's in healthy human beings, because we have a group of healthy, all the guys from the think tank, all the geeks are wearing a bunch of these sensors inside of them. And we've noticed that that's safe, and at this point that we have up to greater than a year of sensing. They demonstrate differences in oxygen concentration pre and post endovascular therapy. And we find those within 10 seconds up to 2 standard deviations of change. So this is significant. And the beauty of it is if you can have that quick of a response to know if what you're doing is the correct thing, I think it will aid and it will help as a GPS. It could potentially create a standard of care and tell you what vessel you're going after. Is my procedure maybe done? Really, does it matter if I do? And now I'm going back to that first slide, is if I, with the right vessel, can show and demonstrate a fantastic increscendo oxygen content, then maybe my procedure is done and I don't have to battle with a lengthy procedure exposing the patient to more contrast and to more radiation. So definitely that time-response relationship shows a trend towards quicker response when you're dealing with more distal vessels. So maybe it could be a tool in more complex, either femoral popliteal or distal disease, not so if you're doing iliacs or if you're doing more proximal disease. Certainly there's an urgent need to validate these procedures and set performance goals in more of an objective manner. So maybe we can give endovascular therapy a fair chance at competing. Apart from MOXIe posing itself as GPS, then for acute on-table decision-making, the very stable nature of its oxygen sensing capabilities opens the door to a new era of follow-up. And I think that's the more exciting thing on top of this. Of course, I'm biased by the fact that I'm an interventionalist and I would love to have more data, but I think from the cost savings, what this device can do is actually it could create new standards. So now that we're all, again, quoting Dr. Slepian, that we all have smartphones. Well, what if we can wand your smartphone over your foot and know what your oxygen content is? And so all these patients in nursing facilities and that are at home, they might not even have to come in for their ABIs when they don't have to. You can probably know if things are going well without them even coming, and probably just through the cloud. Again, I put this always because there's more people today, so I need to say, I like your sense of humor, but sometimes I don't. But coming from a guy that doesn't have a whole lot of hair, I don't know if you could actually say that grooming is optional. Thank you very much, guys.